Hello, JJ's back. I am back. It is Tuesday night. I was on holiday last week, so I missed it last week. So I've got lots of questions to catch up on. Hope everyone is well, and thank you all in advance for the questions. I've got some preordained questions, but always happy to take questions on the fly. If you have anything that you would like to ask me, who are you? You say? Well, I'll tell you who I am. That's me right there. Oh no, that's not me. JJ Staiano, plastic surgeon to the stars, and I am going to do this question and answer session. And if you want to know what you can do, well, I'll tell you what you can do. That's what you can do. Sorry, that's what you can do. Okay, please comment and share. Feel free to share or comment on this thing, what I am doing. So a bit of English language there. Thank you very much. And I know what you're thinking. Is there a podcast available? Well, the answer to that is yes, there is a podcast available. It's available on iTunes. So we put this on iTunes every week, I think. I hope we do. That was the plan. I'm pretty sure we do. I think it's called the Staiano Clinic. I'm trying to make everything the Staiano Clinic. That's my branding, the Staiano Clinic. So, for instance, the YouTube channel, that would be the Staiano Clinic. And, oh, that's it. Just that. Yeah, well, that is it. So, I got me some questions. And Khan's in the house. Big up yourself, Khan. Nice to see you here. We got... Oh, no, actually, sorry. I've got to get this done because I can feel me forgetting this. Oh God. So I'm going to do this because I can forget this. What should I say? What should I call it? I've got to do the competition thing. Where is it? Here it is. Competition results. So what we are doing is we're having an event at the clinic on is it the 27th of August? I'm not sure when it is. I think it's 27th, later on this month anyway, where we got we're going to be talking about Botox, and we're also got a lady who's a stylist who is coming. We're doing an event at the clinic, and we are giving away tickets. I think it's 2 tickets to the event for you and your friend. We had lots of people who've been liking the post and tagging someone. I think you're supposed to do. Anyway, there was a thing on Facebook where if you interacted, you got entered in. And here there's results. Here we are. All. Oh, oops. How am I? So here's the results here, and I'm going to pick on. You know what? I'm going to put them back in the envelope because that's making a bit of a mess there. I'm going to put them back in the envelope, and I'm going to pick one at random. Let's mix it up a bit. So this winner is right. There we go. 26. 26 is the winner. And 26 is Terry Pierce. Terry Pierce, come and collect your award, please. So Terry Pierce, we will be in contact with you, and we will give you 2 tickets to the event. It's on the 27th of August, is it? I'm not sure when it is, but it's late. We're in August now? Yes, later on this month. No, sorry, 27th of August is today. Right. Okay, 27th of August is today. Oh, dear. Right. Well, anyway, it must be September then. It's September. Oh man. Anyway, you've won, Terry. What more do you want from me? All right, you've won an event we're having at the clinic soon. In the next month or 2, we're having an event. Botox styling event. It was on the thing. Oh dear, I feel like a fool now. Anyway, so well done, Terry. Thank you all for commenting and liking and doing your thing. And it was very successful. I was very impressed with Sarah. Sarah set it all up, and I thought it went really well. And I'm just going to try to find the post. Oh my God, that's me. I'm seeing myself. Here we go. A pair of tickets to our VIP personal styling and Botox event held here at the Staiano Clinic on the it'll be announced on the 27th of August. Right. When is the event? Doesn't say. Okay. When is the event? The event is in a few weeks. It's in okay. It's in a short period of time. Anyway, let's move on, shall we? So that's Terry's won the tickets. Looking forward to seeing you there, Terry. And the event's going to be fantastic. It's a September event, September/October event at the clinic. So yeah, good. Thank you for that. Whoa, that went well. Right. Let's do this. The amount of work that goes in behind the scenes of the production of this, I don't think you realize. This thing doesn't run as slickly as it does. It doesn't just get thrown together, you know. I don't just come here and just set up the mic and the background and just do it, you know. A lot of work goes into the production. It's all totally and utterly planned. Right. How much pain will I be in after? How much pain will I be in after tummy tuck and arm lift? Will I be bed bound for weeks? No. Oh, Brenda's got a question. Brenda, nice. How much pain will I be in after a tummy tuck and arm lift? Will I be bed bound for weeks? So first, let's just tackle the bed bound thing first. So an arm lift and tummy tuck is a big combination of procedures, but you won't be bed bound. In fact, I would encourage you not to be bed bound at all. We would aim to get you up pretty soon, like next day, really. That just means getting out of bed, sitting in a chair. It's good to move. One of the risks of surgery is DVT, clots in the legs that can fly up into your lungs, and that happens when you're immobile. Now, you're going to be immobile for quite a few hours during the surgery. Those things we do, we put float-on boots on, these things on your calves, these socks on, give you heparin. But the best thing you can do to stop DVT is to move. So it's not good to be bed bound. Keep moving, keep your legs moving, keep your ankles moving, keep your bum moving, keep taking deep breaths. So I'd encourage you to move, even if it's after big surgery like this. So I wouldn't, you know, you can sit on the sofa and take it easy. I don't expect you to be doing much, just pottering around the house, but try and keep moving. And when you're not doing anything, if you're lying in bed or sitting on the sofa, keep your legs and ankles moving. So that's the sort of bed bound thing. How much pain will I be in? The most of the pain is because it's tight. Your arm's going to be tight. Your tummy's going to be tight. So, you know, you need to bend. You often need to sort of bend forward with a tummy tuck to take the tension off. But also when we do a tummy tuck, we often repair the muscles and bring the muscles together. And that suture in the muscle can be a bit uncomfortable. Every time you cough, every time you sneeze, it's going to hurt your tummy. So it is a bit uncomfortable. So we do make sure you've got plenty of painkillers. Now, you have got to be a bit careful balancing the painkillers because they can make you constipated. They can make you feel sick and dizzy. And certainly constipation after a tummy tuck is not great. So you've got to be, you know, obviously if you're not in pain, don't take them. But if you are in pain, do take them. And usually it can be controlled. And I would say it's sore, it's uncomfortable, but, you know, I hope you won't be in too much pain. But it is quite a lot because you can have both arms out of action and your tummy. So it's quite a lot. A tummy tucking on its own is quite a lot. So to add an arm lift on there is quite a lot. So I think it will be quite uncomfortable and but uncomfortable rather than pain. I would hope. Brenda's got in there. Get yourself in there, Brenda. Coolsculpting, how effective is it really? Wow, massive question, Brenda. Massive question. You know what, Brenda? What can I say? It's a massive industry. So you would have thought it wouldn't be a massive industry if it didn't work. I mean, if it didn't work, it wouldn't be so big as it is. So you would assume it must work. The problem I've got is I think the results are subtle. I think you have to combine it with diet, exercise, lifestyle. If you combine it with diet, exercise, lifestyle, I think you can get dramatic results. The problem is you'll get dramatic results with diet, exercise, lifestyle on its own. So how much is just due to the Coolsculpting? What we really need is we need a randomized controlled trial where you do sort of whatever it is, whether it be Coolsculpting, whatever, fat freezing, or radio frequency, or whatever treatment, non-surgical lipolysis, non-surgical destroying fat on sort of one side of the tummy but not on the other side, or on one arm and not the other arm, one leg not the other leg. So you've got the same person going through the same lifestyle and diet changes, and to see purely if it is a result of that lipolysis. So that is the problem, and I think you do see some dramatic results, but I wonder, I don't know, I wonder if there's been lifestyle changes in combination with the treatments, because you're paying thousands of pounds for the treatments. You're thinking, well, it could go both ways. You could say, I'm paying £1,000 for the treatment, so I don't have to look after my diet and exercise regime. Or you could think, I'm investing in the treatment, I'm going to make sure I get the most of it and I have a good exercise and diet regime. I think I haven't embraced it at the clinic because the treatments are expensive, Brenda. That's why, because it's expensive. If it wasn't as expensive as it is, I think there'd be a lot more to say for it, because I think there is some result, but I don't know if there's enough of a result to justify the expense, at least for my clientele, for my demographic. I think and for my practice, I want to give good value for money. And I think it is very expensive. It's almost as much, sometimes more expensive than having surgery. And I understand people will pay more because they don't want the downtime and the risks with surgery, but the results compared to surgery, which goes predictable and can give very impressive results when you look at before and afters, surgery is like wow. And sometimes with these results are a bit subtle. You have to look at the before and after and say, look at that, there is a bit better. We have to measure and say, look, you've got 2 centimeters here and there. Anytime you have to convince a patient they've got a good result is a bit like, ooh, as I say, if it was a few £100s for a session, I would think it would be more easy to justify. But the cost of it at the moment, at least for my clientele and my practice, I haven't embraced it because it is too expensive for the results that it delivers in my experience of it. But I gotta say, maybe you should be speaking to someone who offers it and does it regularly, because I don't, and they might have a vested interest to say, oh yeah, it works really well, because tricky one, Brenda, tricky one. It's a big question, that big question. What's going on here, Kim? Will my own doctor be able to give me sick note for more time off work? I'm 6 weeks post-op, tummy tuck and breast lift and implanted, and still not up straight, and I can't lift heavy things, and my job is very hard work and a lot of lifting. You don't have to convince me, Kim. That's a big comment. Yeah, I would have thought so. Or your surgeon. I don't think you're my patient or our patient, but if you were, we would give you a sick note. But your doctor, whether it be so when you say your doctor, do you mean your GP or your surgeon? Anyway, either of them can. So your GP could give it, or your surgeon could give you. I think the GPs sometimes charge for them, do they? But yeah, your doctor should be able to give you a sick note. That should be fine, no problem. Brenda, thank you for the comment. Respect to you, and I'm grateful to you for that. This is a patient who has a person, because he's not a patient of mine, contacted me from Sweden. I'm from Sweden. I recently got a tattoo, and I have had so much regret and remorse since. It's not that big, around 2 by 2 centimeters on the front side of my bicep, and all black. I can't find much information about this, and I don't know who to reach out to, but I came across this clinic, and I thought I'd at least send you an email. So I have responded to you by email. Just for the other viewers, I did respond to the email, but I said I would talk about it here. But yeah, there's 2 things with tattoos. Number 1 is the size, and number 2 is the location. So a big tattoo, like today, case in point, I've done quite a big tattoo removal from a tummy, because the tummy's got a bit more spare skin, whereas a small tattoo on the arm will be on the sort of biceps area would be more difficult to remove. Similarly, on the hand, there's not much spare skin on places like the arm and the hand, and so it's more difficult to remove. So I would say 2 by 2 centimeters on the arm, it might be quite tight, it might leave an ugly scar, so it's not great. Now if it's all black, then and to be honest, in general terms, I normally say the first point of call with tattoos is your oh god, I'm back on the last one. laser. And certainly if it's all black. Laser does struggle with the pigment sometimes, but laser is often the first port of call. If it is, if laser doesn't work, or for whatever reason you want to go down the laser route, you could potentially look at excision. But I think 2x2 on the forearm, we might not be able to get all that out in one go. And so you might need what's called a serial excision, where you have it done in one go, close it tight, and then you come back 3 to 6 months later. And I know you're asking about where to go. I would say any fully trained plastic surgeon should be able to help you with that and discuss the pros and cons of that. So I would look for a plastic surgeon in Sweden, and good luck with that. Kim's come right back at me saying GP. Yeah, GP should be able to do it, but although the GPs sometimes charge, I think I don't want to get irate GPs on the line now to tell me they don't charge. I think there's not a little sign when you get the GP. Anyway, GP should be able to give you a sick note, Kim, or your surgeon should be able to give you a sick note also. Hannah, I really want rhinoplasty and get married September 2020. Is this enough recovery time? Bearing in mind I haven't even had a consultation yet. September 2020, so it's a year. Yes, that is fine, Hannah. I've got a question about rhinoplasty. Is that you, Hannah, who asked me the question there? I've got a question about rhinoplasty. Is it dark in here? Do I need to turn the light on? Has that helped? Not sure. Yeah. So I've got a question about rhinoplasty recovery. So I will talk about that. But yeah, I think a year should be fine. But yeah, but yeah. Get married. Yeah, is this enough recovery? It's enough recovery time. I mean, you're not be 100% fully settled, because it will be less than a year post-op, because it would only be a year post-op if you had surgery within the next few days. But yeah, that sounds reasonable, Hannah. Right. You haven't asked a question. Okay, so someone else has asked a question about rhinoplasty. Okay, well then stay tuned, Hannah, because the question after this next question is a rhinoplasty question, similar to what you're saying, really. So the next question is, we've got a visual question here. Love this. Can you explain the breast uplift diagram and what the different options mean? I know what you're thinking. What breast uplift diagram are you talking about? Well, this breast uplift diagram. Check that out. All right. That's the breast uplift diagram. And no. How do I? Huh? That's the. Yeah. That's the one. Right, so I think I turned everything off then. Sorry about that. Okay, I'm still, what I'm trying to do is yeah, that's it. That's what I was trying to do. Right, okay, sorry about that. So I can't point, can I? No, okay. So can you explain the breast uplift? So basically, everybody wants less scarring. Can I have a breast lift with less scarring? Now, obviously, if you said, can I have less scarring or more scarring, people would want less scarring. Yeah, no one's going to say, oh, yeah, I'll have more scarring, please. So basically, the thing about a breast lift is, one thing that all breast lifts do is they lift the nipple. So there's always a scar around the nipple. To be honest with you, I haven't really, this crescent one, this one on the far right, the crescent one, don't really know. I mean, you could just do a crescent lift. If you had a minor asymmetry of nipple height, you could maybe try and lift the nipple a bit from a crescent. But really, the starting point, I think, if you're talking about a breast lift, is really the donut or circumareolar mastopexy, which is a scar all the way around the areola. And the problem, as I see it with breast lifts, is everyone wants minimum scarring. But if you're going to get rid of any scar, it's the one around the areola you want to get rid of. And that's the one that you have to have. The other scars are less of a problem. the vertical scar and the horizontal scar are less visible than the one that goes around the areola. So that's the problem I've got with the techniques which have less scarring. Now, the good thing about the circumareola or the donut mastopexy or Benelli lift is that it just gives you a scar around the areola, and because you have the interface of areola to normal skin, you know, it can fade pretty well. Now, the problems with it are because you're not taking any other skin away, all the skin removal is from the circumareola. You are literally taking a donut of skin out and cinching it down. And that means you're cinching a bigger circumference into a smaller circumference. And that means that the scar is puckered a bit like it is for an areola reduction. So the scar is always puckered, although it does tend to settle. There's a risk that it can stretch. So you have to use either a long-term dissolving or a permanent suture to prevent that stretch. And to be honest with you, in my hands and in my experience, it doesn't give a great lift. It does tend to flatten the breast. It doesn't give much projection to the breast, and I don't like it personally. It doesn't give a very significant lift. The other techniques, the lollipop or circumvertical, and the anchor or inverted T, the other two on the left-hand side, are more scarring, but because they're having more scarring, more skin can be removed, and therefore more of a lift can be achieved. So I would tend to go more towards those ones, because obviously, you know, you say I don't want the scarring, or don't have anything. That gives zero scarring but zero lift. So it's a balance between volume of scarring or amount of scarring and amount of lift. More scarring, more lift. So the lollipop goes round the nipple, so you can lift the nipple up, but then also removes skin in the side-to-side dimension. So not all of the skin is removed as a donut. You're also removing skin on the side-to-side dimension, so you're not getting quite so much as a pucker around the areola, because you can correct that skin excision into that vertical scar, and it narrows the breast, which is often nice to give a pleasing shape of the breast and to narrow the breast. The problem is it doesn't take any skin in an up and down direction, and certainly if you look on a side view on someone who needs a lift, who's got a bit of a droop to their breast, there is quite a lot often of excess skin in the sort of up and down direction, and so that's where the anchor lift comes in. Now, or I should say, if you're not doing an anchor lift, you're doing a lollipop lift, there's a risk of a fold or a pleat or a dog ear or a bunching at the lower end of that lollipop incision, because that up down skin has not been removed. So what you tend to do is you tend to pucker and cinch up that vertical scar to shorten the vertical scar, and that can leave folds and ridges. And certainly one of the first people who popularized the lollipop lift, which was Madeleine Lejour, which was more of a breast reduction technique. She would often do she would call it a second stage, taking out those wrinkles and folds at the lower part of that vertical incision to give a short horizontal incision, and she would call that a second stage rather than a revision. So to be honest with you, if you're, and again, this is just my own personal experience and my own personal technique, I often will do a lollipop, certainly when I'm doing a lift and implants or something like that, when I'm not taking a huge amount of skin out. But at the end, when you get that pucker, when you get that bulge, I will just cut it out and make a short T, because that short T, you never see it. And it just takes out that pleat, takes out that ridge, that dog ear, that bulge, and just helps to take out some of the sort of vertical dimensions of the breast. But for a full lift, an anchor lift, in my hands and in my experience, is often the best way to give a lift. If it depends on how much skin needs to be removed. If it's only a small amount of skin, a lollipop or circumvertical might be the way. But certainly if you need more skin removal, an anchor is the way to go. And often if you get that scar in the fold, it often heals pretty well and is hard to see. So basically it's increasing scarring and increasing levels of lift, and it's also up to the surgeon as well. Some surgeons have got a view and will think the lollipop lift's great and always do the lollipop. Some will always do the anchor, you know, because you've got to look at what results they're getting and go with that. Like I always say, go with the surgeon. Don't go too much on the technique. Go with the surgeon. You know, you can get good results from all of them probably, and bad results from all of them. Go with a surgeon. Don't say I want this technique, because a bad surgeon doing a good technique can still get a bad result. Does that make sense? Right. Lynn and Mariana, we got some. Oh, hold on a minute. Hold on. That was excellent visual representation. I'm very, very happy with that. I am 10 weeks post FDL. That's fleur de lis tummy tuck. I have a large lump underneath the T-junction. I'm massaging it all the time, but it does not go. Doesn't make any difference. What could this be, and will it go away? Oh, tricky one, Lynn. I would say go to your surgeon. Always best. What could it be? Well, it depends if it's a lump in the skin or a lump underneath the skin. If it's a lump in the skin, it could be a reaction to suture. If it's underneath the skin, it could be a fat necrosis, could be a bit of dead fat, could be localized seroma, could just be scar tissue. 10 weeks is not that long, Lynn. 10 weeks is sort of still relatively soon, especially for a big op like a fleur de lis tummy tuck. Sometimes when you get that, because you're doing that sort of T-junction, you're pulling the skin together at the top, you might get a bit of bunching underneath it. And it just might be a bit of scar tissue and it might just soften over time. Massaging it is good, but I think if it's not expanding, if it's not painful, if the skin's not red and angry, then I wouldn't worry too much about it. But you're obviously concerned because you're posting here. So I would say talk to your surgeon and get some advice from your surgeon. But it doesn't sound like anything too worrying. And I think massaging it is probably a good idea. And it depends whether it feels like it's fluid or firm. Because if it's fluid, it could be seroma, which could be aspirated. What are your thoughts on buccal fat removal? Does it aid you? Does thy fat actually support anything? It's not a question to support anything. So it's more of the aesthetic. So basically, I don't do facial aesthetic surgery myself. Khurram Khan does it at the clinic, but I don't do it myself. But we've moved away a bit from fat removal for anti-aesthetic facial surgery. So we used to often remove fat from the face to for cosmetic surgery, but we're moving away from it now, Mariana. And does it aid you? Interesting way you've put that question. So you obviously have heard that it might, and you've got to be careful with removing fat from the face because you can get a sunken look and it can age, and as time goes on, we do tend to lose volume in the face. You just have to look at a child, look at a baby, look how full the cheeks are, look how much fullness they've got in their face, and basically that's what we're all trying to do. We're all trying to revert back to look like a child, or you look at a young person, the facial structure of a young person. That's what we're all trying to do, and they're often quite full. So we are moving away from removing fat from the face and actually moving more towards adding fat to the face. So fat grafting to the face to actually add volume to the face rather than taking it away. So it is more of an aesthetic thing rather than the fat supporting anything. You can remove fat from the face, but we're moving more away from removing fat. But again, I could go back to talk to your surgeon and weigh up the pros and cons for you, because if you've got excess in a localized area, then it may be relevant to remove or appropriate to remove some fat from that area. So Lynn says it is firm. So then maybe less likely to be a seroma then, Lynn. So maybe massaging it sounds like a good plan. But yeah, nothing too worrying, Lynn, but always best to talk to your surgeon for advice on that. Oh, sorry, I said that we were having a question on rhinoplasty too, and then I started talking about these. So here we go. Here's the rhinoplasty question. After rhinoplasty, how long before the swelling is gone and you see the true result? So thank you, Mariana. So rhinoplasty is a tricky one because subtle swelling, subtle changes, millimeters of difference can make quite a significant effect on the aesthetics and the proportions and the geometry of the nose. So it is really important to be patient, and this is why it's good to have a proper conversation with your surgeon. Personally, I don't do rhinoplasty. I would put that Khurram does, but I don't. But I would just put that out there. But it is ones that you need proper consultation beforehand to appreciate just how long it takes for things to settle. So the first few weeks there is quite a bit of swelling. Well, the first week or so there's bruising. Bruising is often underneath your eyes, so you look like you've got black eyes. There is bruising to start with. The swelling's for the first few weeks. 6 to 8 weeks, swelling sort of starting to go down, but I always really say 3 months is when things really start to settle. Now, who was it? Hannah. Yeah, Hannah was asking about getting married in a year. So 3 months things start to settle. Now, careful. Now I'm saying start there. So start to settle out around 3 months, but it can be 6, 12, even 18 months for things to properly settle. So I think around the 12 mark, things are really starting to settle nicely, but there might still be a bit of swelling here. There might still be a bit of thickening from the scar tissue, funny sensations. So it can take, 12 months or more for the final result to really appear. But I think things start to settle around 3 months, and then 6, 12, 18 months for the final result. So you have to be really patient with it. But yeah, 3 months is the simple answer, I guess. Got a lot of facial questions here. Loving it. Happy to tackle them. I'll bat them away. I'll give them a go. Well, not bat them away. What are the options for getting rid of a double chin? Again, I don't do facial aesthetics myself, but I can give you, broadly speaking, the options. Now, the first thing I would say is, lose weight. If you're overweight and you've got fullness in your chin because you're overweight, lose weight. And the hope is that the skin will recoil afterwards. That would be the hope, and obviously that would be it. Cured, double chin cured. Then sort of moving up in complexity with a double chin, and you might say, well, I've lost weight and that's why I've got this sort of sagging chin, because I've lost weight and I've got skin. You can consider liposuction. Liposuction to the chin is a good technique, and if you're young, if you've got good skin quality, if you don't smoke, then there's a good chance that skin will recoil and improve that skin contour. So liposuction is something that you could consider to get rid of that fullness there, sort of after weight loss. They're probably the sort of easiest techniques. Then you get into sort of more skin tightening techniques like neck lifts, which is often combined with the facelift, which tightens the skin of the chin if there's a lot of laxity there, and if that skin really isn't going to recoil, then you've got to look at cutting skin out to tighten it, just like breast lifts and tummy tucks, like everything else. If the skin doesn't recoil, then you have to sort of cut skin out. Now, when we tightening skin on the neck, we often hide the scars around the ear to pull and tighten the skin to get a lift on the chin and a pull on the chin, and that will be the sort of final result, the final option to improve the neck and the chin contour. Amiz Lovep, can you do arm? Nice, to the point, Amiz. Don't mess about. Can you do arm? No extra letters, no extra words. Just get there. So, can I do arm? Yes, I can do arm. Amiz, I'm thinking you're talking about arm reduction. Are you sort of arm tightening, brachioplasty we call it? So I can do arm. The problem with doing arm is that it does leave quite a long scar. Where's my arm? There it is. So it gives a scar down to your elbow. Quite a long scar when you're doing an arm reduction or an arm lift, but it's something that I certainly can do, that is for sure. What about this one here? Hey guys, what do you think? Hey guys, what do you think of this? Can a thigh lift be done so the scar is under the buttocks? Interesting. I've seen somewhere the thigh lift can be done so the scar is under the buttocks. Have you heard of this? Scar under the buttocks for a thigh lift. Right. What you got to think of is this stuff, people make a thing about surgery and all that sort of thing, that it's a big deal. Think about it, right? What are you doing? Think about what you're doing. And what if you had to do it? Where would you make your scar? Where would you get the pull? So because the scar is where the pull is. So a thigh lift scar under the buttocks, well, that would lift the posterior thigh, the back of the thigh. I guess if you've got a lot of laxity in the thigh, in the posterior thigh, then you could. But it's not where most people complain of the laxity. It's usually medial. It's usually the sort of inside of the thigh, the inner thigh, that's the problem. And so the scar usually goes there. Excuse me. If you've seen a scar in the buttocks, that's probably more of a buttock lift, trying to give more definition to the buttock crease, and a more rounded buttock is where the scar in the buttock would go, rather than the lifting the thigh. It's more of a buttock lift, and giving more roundness and definition to to the gluteal fold, the fold where the buttock meets the thigh. So it's not so much of a scar for a thigh lift, and it's certainly not something I've really seen for a thigh lift, but it is more for the buttock. Amiz is back, and Jackie is back too. Look at this. So Amiz, can you do arm reduction if BMI, not blind, okay, is 35, fat, not excess skin? You know what, Amiz, I think BMI of 35 is a bit high. We normally work off a BMI of 30, saying if your BMI is less than 30, you're going to get less risk of complications than if your BMI is over 30. So 30 is where we would really be looking at ideally, but you also need to be happy and stable with your weight. But I think 35 is quite high. And the reason I say that is because two reasons. First of all, first question is, are you happy with your weight? So if you're happy with your weight, then maybe it's okay. But often you might say, well, actually, no, I'm not happy with my weight, but I'd like to get my arms done, and then I can, feel better about myself and go to the gym and what have you. If you do surgery on someone who's overweight, and then especially something like an arm lift, and then they go on and lose weight after that, they might be left with more redundant skin, because you often get more redundant skin when you lose weight. But that's why you need to lose weight first, because then you can cut that redundant skin out and tighten it more. So it's always best to lose weight first. But the other thing is, the higher your weight, the higher your BMI, the more your risk of complications. And the problem with a surgery like an arm lift, it is quite tight. It goes up into your armpit. It's hot and sweaty in your armpit. There's a pretty high risk of complications anyway, with wound healing problems and wound healing problems, I guess, is a big one. But also if you're overweight, pneumonia, chest infections, DVTs, your risk of complications in general are higher. So generally speaking, it is better to lose the weight first. You're saying you've had a bypass 3 months, not lost much yet, but want arm lift so bad. Yeah, you're better off waiting, Amiz. Really, I'll tell you why. You're going to get a better result. You don't want to spend thousands of pounds, get an arm lift now, lose weight, and then a couple of years down the line or a year down the line still have baggy skin there. You'd be really annoyed with that, and a scar. So I know it's frustrating, but if you've only had a bypass 3 months ago, I would let it do its job and give it time, and it will be better if you can lose weight. You'll get a better result, and you get less risk of complications if you can lose weight first. But sorry, Jackie. Sorry, hold on a minute, Jackie. What happens if you have keloid skin? What terms of what, Jackie? Amiz, thank you. If you have keloid skin, do you mean, well, if you're having surgery, you've got risk of getting another keloid. So I'd be very worried about having further surgery if you've already got a keloid scar, but or a history of keloid scarring. But if you have a keloid scar, there are things that can be done, things like steroid injections, intralesional excisions, pressure clips, and pressure drugs, silicone gel, silicone sheets. So there are things that can be done for keloid skin. But if you are considering surgery and you've got a history of keloid scarring, then I would be concerned about that. So I'm not sure what angle your question's coming at. So I got both angles. Traveling with your compression garment. Traveling with your compression garment. On holiday after a tummy tuck, do you advise traveling with your compression garment and bind it on, or can you remove one or both just for the flight? On holiday after a tummy tuck. That's a weird question, isn't it? Does that mean you've had tummy tuck abroad and you're coming home, or you've had a tummy tuck and then gone on holiday? Because the first thing is, I say I wouldn't go on holiday after a tummy tuck. I would wait until it's all settled and all healed, because one of the big risks with a tummy tuck, not big risks, but one of the risks is a DVT, clots in your legs that can fly off into your lungs. That can happen after any surgery, but it's a higher risk after a tummy tuck, because a tummy tuck, you tighten the tummy and you reduce the venous drainage from the legs, so you're going to be more likely to get clots in your legs, which can then fly off into your lungs, and that can be a really serious complication, and that risk is increased when you're flying. So it is not good to fly, or at least not in the first, I normally say 6 weeks, 6-8 weeks or so after a tummy tuck. You ideally don't really want to fly, because you want, well, two reasons. First of all, you want to get you want to reduce your risk of DVT, but also healing and stuff like that. If you get any little wounds, things, then that might be an issue if you're abroad. So if you are, so would you traveling with your compression garment and binder, or can you remove one or both just for the flight? It's a tricky one that, because, so let's assume you are traveling with your compression garment. Now the compression garment is good for swelling, but it is going to increase the tension on your tummy and increase your risk of DVT. It's a tricky one, and I think it's a balance. I don't really want to say for your here we go, my opinion only. It's really up to your surgeon, because it's a balance between the binder is helping you with the swelling and maybe giving you some support and making you feel better, but it is putting more tension on your tummy, so reducing your venous drainage from your legs, so increasing your risk of DVT. If you ask me, right, it's just my opinion, I would say a DVT is more of a problem than swelling and discomfort from your tummy tuck, so I would say leave off the binder. But that is just my opinion. If you, yeah, because I'd be more worried about a DVT than swelling and discomfort from the surgery. But it also depends on how long after the surgery it is, and how bad your swelling is, and things like that. So you know, you might say, my swelling's really bad, and I take my binder off for an hour and it really hurts, and I've got, you know, so, well, you know, you can wear the binder then. But if you're going to do that, keep your legs moving, keep your ankles moving, keep walking around the cabin, you know, keep everything circulating. Khan says she's going on holiday at 4 weeks. Okay, well, that's okay. So she's going on holiday at 4 weeks. So yeah, 4 weeks is good, is better than, you know, I normally say to keep the garment on for 4 to 6 weeks. So in that case, again, up to your surgeon. But if I would say around 4 weeks, sort of time you can stop using the garment anyway. Sometimes big supportive pants can help instead of the garment. But for me, I would say I would not use the garment while you're flying. Yeah, I would remove them for the flight, and then maybe wear them again when you're out and about on holiday, and just give you a bit of support when you're out and about. And just around 4 weeks is sort of time you can think about sort of, you know, coming off with the garment anyway. So yeah, that's not so bad. 4 weeks. So yeah, thanks, Khan. Thanks for clarifying that. Thank you. I was referring to scarring and its impact, and you answered. Thank you, Jackie. That's helpful. Here we go. What we got here? When can I swim? When can I swim after a tummy tuck? First thing, depends if it's a sea or a swimming pool. The sea is really good for wounds. You know, when those airplane pilots got shot down, the ones that got shot down over the sea and landed in the sea, their wounds and their burns in particular heal a lot better than the ones that were that weren't shot down in the sea. The sea water is really good. Salt water is really good for wounds. So you know, as long as you haven't got any dressings on, you can go in the sea whenever. When in terms of the pool, the swimming pool, I normally say, look, if you have got a dressing, if it is exudative, if there is stuff on your underwear, or if you're wearing a gauze pad or something, and there's stuff on it, then I wouldn't go in the pool. But if once it's dry, then you can go in the pool. 2-3 weeks, something like that, usually. Now that's going in the pool. Swimming, I guess, yeah, maybe I should have thought this through a bit more. So swimming's a bit more of a big thing. So that's getting into the pool once the wound is dry. So that's 2 or 3 weeks. Swimming is quite an activity. So actually, maybe a bit of gentle breaststroke might be all right, but not too crazy with the front crawl. No butterfly. You know, you're looking at 6 weeks before you're doing anything active, because it's going to make your tummy swell. So gently, you know, getting in the pool, and maybe a little bit of gentle breaststroke, but see how it feels. It might make your tummy swell and be a bit uncomfortable. But 2 or 3 weeks you get in the pool. 6 weeks before you be doing anything sort of proper swimming, but you can do sort of gentle swimming in the first 2 to 6 weeks. Is that helpful? Got through that one. I think I got through that okay tonight. Yeah. Right, here we go. Hi there. I have seen your live feeds on a Prague plastic surgery Facebook group. That's good. Welcome everyone in the Prague Plastic Surgery Facebook group. My live feeds are there. I'm loving that. That is the sort of publicity we need. Thank you. I was wondering if you could help me. I was initially I was looking initially at having a breast uplift and implants in Prague, but I think my husband and myself would feel more at ease having surgery in the UK. I've sent several pictures to a couple of surgeons, and they both said that I need an uplift only, which is quite disappointing as I'd really like bigger boobs. Nothing too big though. I'm unsure as to why they don't think I'm a candidate for implants. Can you possibly tell me what you think and what you'd be able to do? Many thanks. I haven't seen pictures, so that this is, I'm just basing it on what is said there. I haven't got the pictures of what we're talking about here, but just in general terms, the thing is, when I talk about lifts and implants, God, look, I've got really big hands there. They're not that big, really. Small hands. Right, that's enough of that. So when I talk about lifts and implants, I say broadly speaking, there's always exceptions to the rule. Shape and volume. If it's mainly a shape problem, it's a lift. If it's volume problem, it's implants. If it's shape and volume, it's lift and implants. So what I can see happening here is you have got a shape problem. So the surgeons are saying you need a lift. And you're saying, well, actually, I want to be a bit bigger, but nothing too big. Now, the problem comes here is a lift and implants. When you do a lift and implants, it's got quite a high complication rate because a lift makes everything tight, an implant makes everything tight. So it's got a high complication rate, the risk of wound breakdown. If the wound breaks down, if the implant gets infected, you have to remove it. So it's quite a big deal, a lift with implants. And when you're doing a lift with implants, if you're putting a small implant in, it might be, and I don't want to talk for the surgeon. I don't know what they're thinking. I guess the thing to do is ask them what they're thinking. But what I'm thinking they might be thinking, there's too many thinkings in there, is that maybe if you're going to have just a small implant, is it worth taking on the risk and the expense of having a lift with implants? What about just having a lift? See what you think. You might be happy when the volume's on a better place in your chest, higher on your chest. You might be happy with that volume, and you might not want implants. Now, so that's what I'm thinking. I'm also thinking that actually there's a lot of surgeons. I know there's a lot of surgeons, good plastic surgeons. They're not bad surgeons who don't do a lift with implants. They won't do it in one operation. They stage it simply because it has got a high complication rate. So you might be sending it to surgeons who just don't do a lift with implants, who look at your breast and say, look, you need a lift. We're going to do a lift first. If you want implants, I'll do that as a second stage later on. It is more expensive doing it that way, but you reduce your risk of complications because you do your lift, you get yourself healed. If you have any infections or anything like that, it doesn't matter quite so much because you haven't got an implant in there. And then later on, you can go on and have implants. So it is more expensive, but it does reduce the risk of complications. And there are many very well-respected surgeons who do it that way. I do a lift and implants in one operation, but I do warn everybody that it has got a high complication rate, and there is a risk of complications. But if you do want to be bigger and lifted, it is probably the best way to do it. And it depends on how much bigger you want to be. As I say, if you only want to be a little bit bigger, there's a small implant, I might be thinking, is it worth taking on those risks and those complications? So that might be what they're thinking, or it might be that they just don't do lifts with implants. But if it is shape and size, if you say I'm a B cup and I want to be a D cup, well, that's not going to happen with a lift. A lift is you're still going to be a B cup, But if you're like a D cup, and I'm like, well, I'm happy being a D cup, but I just want them fuller. Well, then maybe a lift on its own. So if you're happy with your cup size, then maybe a lift on its own is where you want to be. Baby. Venencia Faria. I got a very bad ripe on your arm. I got a very bad ripe on your arm, on my arm. You've got a bad ripe on my arm. I've got a very bad ripe. What could that be? Even with predictive text, what could that be? I got a very bad ripe on your arm. Valencia, I'm not Venancia. I'm not sure what that comment signifies, but I'm sorry to hear that. And I don't know what that. I don't know if that's a predictive text issue, but a very bad ripe on your arm. And Khan is saying I share them in all groups. Khan, you... Oh, hold on a minute. I got to... Wait a minute. First of all, let me just big up Sean for a minute. Khan, Khan. And I've emailed you and I've called you Karen, haven't I? I haven't called you Karen. It's the predictive text puts Karen in. I put Khan in, I press return, and it says Karen. So that's not me spelling your name wrong. It's the predictive text. When you put it on Facebook, it just says Karen. I try and go back and change it back to Khan, but I am immensely grateful for you, Khan, for sharing it in all groups. You are a stalwart and a great supporter, and I'm very, very grateful to you for that. So thank you very much, and hello to the groups. If I'm if I'm in a group right now, well, I'm not because we're doing it live. But if I'm being shared in a group, hi, I'm Jonathan. So let's see what's going on with Venancia. Venancia, I got a ver scar ripe on your arm. Right, that was the first one. I got a ver scar ripe on your arm. Then that was amended to I got a very bad ripe on your arm. Are you saying you got a bad scar on your arm, maybe? Got a bad scar? Venancia, you can always direct message me if you want to show me a photo of your scar. I'll have a bash at giving you an opinion on that. And Khan is going to let me off for calling her Karen and Sean and whatever else I called her. So thank you for that, Khan. And it's totally my fault. I can have no responsibility for that. It's all Facebook's fault. Right, what we got going on here? We have got a question here which says, how long after surgery would you recommend starting MLD? You guys like your TLAs, don't you? MLD. So I think that is manual lymphatic drainage, I believe. So manual, I don't particularly recommend manual lymphatic drainage, not because I don't think it's not good, but I don't think it's good or bad. I just don't find it's something that's crossed my transom. So I wouldn't particularly recommend it at all. But if you wanted to have it, then that would be fine. And I guess you'd really want, it depends on the surgery and it depends on whether the MLD is going to be, they're going to be going around your scars, and if the scars are tight and if there's any wound healing problems. But a few, 2 or 3 weeks maybe, I don't know. And it'll probably be up to the MLD person. They probably know better than me. But I guess you'd want to get everything pretty well healed before you start massaging too much. But yeah, but no, but yeah. Big question. Looks small, but it's big. Some people say it's got to be changed every 10 years. Some people do routine scans and all that sort of stuff. Everyone's different. And anytime people do different things, it mean there's no right thing to do. But the first thing I'd like to say is this. Right? Disclaimer. This is my own personal opinion. And it's no substitute for an in-person consultation with your surgeon. So, speak to your surgeon, and there's different views and opinions on this. And as I say, anytime there's different views and opinions, that means there is no good, not no good. There's no sort of right answer. So you've got to think about what would be the reason for needing your implants replaced. Let's get that off. Sorry. What would be the reason for needing your implants replaced? So obviously, if you get an infection or if you get a problem with your implants, you're going to need to a rupture, the shape changes, you have an accident, the shape changes, and they look strange. If things go wrong and they start to look abnormal, then they need to be replaced. Now, we always offer everybody yearly follow-up for everybody, not just implants, just to keep an eye on things, just to keep check on things. But I've got to say, the driver for changing implants comes from the patient. It comes from you. I wouldn't tell people that they need to have their implants changed. The common reason later on is capsular contracture, scar tissue forming around the implant, making that implant feel hard. But you don't have to have it changed just because you've got a capsular contracture. And normally it takes about 5 or 10 years for that to happen. But you don't have to have them changed. You might say, I'm really worried about this. And we'll be like, oh yeah, it's capsular contracture. It's nothing to worry about. It's probably going to get worse, but it's very slow to get worse. The problem with changing your implants when you've got capsular contracture is that if you change your implants, you take all that scar tissue out, put new implants in, it's quite a big operation. That another capsule comes quicker after the second operation because you're creating more scar tissue every time. And so I always say to people, leave them as long as you can, because you don't want the clock to start ticking on the second set of implants. So unless it's really uncomfortable and misshapen, I would try and avoid further surgery. You want to minimize the amount of operations on your arm. And so unless you've got a problem, the shape has changed, if there's a swelling, if there's a lump, obviously you need to get it looked at, particularly now with this ALCL thing that's come up with implants. But certainly if you haven't got a problem, if you're asymptomatic, if they look fine and you just had them in for 10, 15, 20 years, if they're not causing you any bother, I would avoid surgery personally. I would leave them alone. Again, there's no substitute for an in-person consultation and go and talk to your surgeon and get things checked out and what have you. But the driver usually comes from you, the patient. If you need it, if you're going to have your implants changed, it usually comes from the patient to say, look, they're hard, they're uncomfortable, don't like the look of them, my breasts have drooped, they're too big, they're too small, whatever. That would be the reason for replacing them. And that is, as I say, is coming from the patient. Here we go. Venencia, scar on my arm. So Venencia has got a very scar on your arm. Very bad scar on your arm. Okay. Scar revision, we can't remove scars, and all we can do is change them. So the question is, first of all, how old is the scar? Really got to wait at least a year for a scar to mature before you think about doing stuff. Within that year, you can start massaging it, moisturizing it. You can use silicone dressings, silicone sheets, silicone gels, particularly if the scar is red and raised. So those are the sort of things you can do within the first year to help with the scar. Once the scar's mature, so I'd say at least a year really, you've got to think what's wrong with the scar. So is it lumpy? Is it hypertrophic? Is it keloid? There are things we can do for those sorts of scars, steroid injections, even intralesional excision, but that would usually be a last ditch. Is it stretched? Is it wide? You might be able to revise it and make it narrower, although there's always a risk it could stretch again. Is it the position of the scar, the angle of the scar? We can always change the angle, change the position, but we're limited as to what we can do in terms of scarring. We can't remove it. We can change the direction, we can change the angle, we can move it slightly, we can help with stretched or dented scars or raised scars. But if it's a mature, flat, skin-colored scar, there's not a lot we can do. It's, it depends on how it's bad as to whether anything can be done. Been a big one tonight. I think you'll all agree that. This is the last question. If anyone's got a question, then they can please. And if Financia, if you want me to elaborate on that. Oh, here we go. Elaboration incoming. More than 35 old. More than 35 old. 35 years. Is it old? 35. So if it is old, then yeah, it's that's good. You left it to settle. So yeah, really, if it's raised, dented, stretched, or in a funny position, we might be able to change those things. But if not, then we're limited as to what we can do. You can always send me a photo if you want, Venancia. Do a direct message me a photo. I'll have a look. Do you perform hybrid implants? Now, I think that what this person is referring to is implants with fat grafting. And no, I don't. And the reason I don't is because I don't think it's necessary. The person initially got in touch asking about fat grafting to the breast. And I'm like, well, fat grafting to the breast for cosmetic surgery, for reconstructive surgery is very good. And I used to do it all the time for breast reconstruction. It's a brilliant technique, fat grafting, but it's subtle. It's very good for 3D contour irregularities. It's very good for adding volume to one breast if there's an asymmetry. But for both breasts, for cosmetic augmentation, it's not great because the results are subtle. It's a small volume increase, less than a cup size. It's quite expensive. It's similar price to breast implants. Often has to be repeated. So ideally, you want someone with a lot of fat and big breasts, but those are the people who don't tend to have implants. The people who have implants usually have not much fat and small breasts by definition. So you're limited your donor sites, you're limited with your recipient sites where you can put the fat in. So in my experience, cosmetic breast augmentation using fat grafting is subtle, the results, and it's not, you've got to be very careful in terms of patient expectation because of the expense of it. And the gold standard, the best way to do to enlarge a breast is still breast implants. I totally understand why people don't want breast implants. They're worried about all these media stuff, breast implant illness. This particular patient's worried about ALCL, rippling, capsular contracture, infection. There's all sorts of things that can happen with implants, so I totally understand it, but they are still the best and most predictable way to enlarge the breast. Now, hybrid implants means, I think this is what they're referring to, is having implants and fat grafting. So you put implants in and fat graft over the top. I don't do that. The reason I don't do that is because that's quite expensive, because you're doing implants and fat grafting, so that's going to be an expensive operation. And why would you need it? If you haven't got enough cover over your chest, I tend to use the muscle, go under the muscle to cover the implant. And modern day implants, cohesive gel, textured or polyurethane foam implants, are pretty good in terms of rippling and edge visibility or palpability. You often do feel them early on, but they usually settle. And if they don't settle, then you could always consider fat grafting at a later date. I think that would be a better way of doing it rather than doing fat grafting to start off with, because many people will not need that fat grafting at a later date. Now, you do hear a bit more about it in America, where they use more saline implants, they use smooth implants, which have got a slightly more risk of rippling and what have you. So if you are a bit more worried about rippling, then I can sort of see the advantage of it. But rippling, touch wood, is not a common problem. But if you do get rippling, then fat grafting is good for it. But I say, if you are very slim, usually putting implants under the muscle gives it a bit of coverage in the cleavage area, and certainly the fat grafting will not enhance the volume significantly, because the implant gives the volume, and the fat grafting would only be giving soft tissue cover. And so I would tend to go submuscular with the implants rather than doing a hybrid combination of fat grafting and implants, is where I would go with that. Final word to Venencia. Venencia is going to send me a photo, so that's good. Thank you, Venencia. I'll have a look, and I'll put my oar in. So thank you all for that. Thank you, Khan, for sharing this on the pages, or the what is it, the groups. Thank you very much for that. Very grateful for the comment and the comment and sharing. So sharing in capital letters, I think you noticed there. So Khan's doing it. Are you? Thank you for that. All in fair warn, that is 2009. I'm going to check myself out of here, but don't fear, don't panic, don't worry, because I'll be back next week, Tuesday, 7 p.m, right here, or maybe there, and I will be answering your questions. And please post them on Facebook, or message me, or email me, and I'll be very happy to give you my help and advice and opinion. Thank you all. Lovely to be back. First week back from holiday. I had a lovely day today, and it's really good to be back. And thank you all for your comments and your sharing, etc. I am going to check out of here and go and see if there's any dinner left. So wishing you a very good night. Good night.